My name's Nicola. I'm a project manager at the Yorkshire and Humber Academic Health Science Network, and I'll be facilitating this session today. And this session is around models of care. So we'll be looking at things like digital platforms, patient consent, and cancer detection. It will be a really fast-paced session, as Peter mentioned, and one of my jobs is to keep it to time. So forgive me if I'm a bit strict and need to keep people to time, but I just want to make sure everyone on the call has a chance to present. If you're not speaking or presenting, please do keep on mute and cameras off, just to make things smoother from a bandwidth point of view. And please do put any questions that you have in the Q&A function at the top of Teams next to the chat function. And if you could just mention which innovator or speaker it relates to, if it's for someone specific, that would really help us out. I will collate all questions and answers to share with you afterwards. So without much further ado, because as I mentioned, we are very tight on time, I will just bring up my agenda. So first up, we have Kevin from Aseptika. So I will stop speaking, and Kevin, I will hand over to you. Thank you.
Okay, thanks, Nicola. I'm going to share my screen. Can you just let me know if you can see it okay? Sorry.
Not yet, but it's
doing something very strange. Come on, you can do it. Can you let me know if you can see that?
There we go. Yes, thank you.
Fantastic. Okay, thank you ever so much, Nicola. I'll try and speak quickly. So I'm Kevin Auton. I'm the founder and managing director of Aseptika. And this morning I want to talk about supporting children and young people at high risk of further asthma attacks. So these are children and young people who've already had one asthma attack or have uncontrolled asthma and are being seen in the secondary or tertiary care outpatient system. And to give you the story, the answer right at the end, at the beginning. So we found in a recent study that 2 out of 3 of children and young people outpatients can be successfully supported to self-manage using our platform and referred back to community care with really good inhaler adherence and asthma control. And this will have a really big impact, obviously, on waiting times, particularly for the critical first appointment for new patients, but also on the number of journeys and overall carbon production. So just very briefly, a little bit about the company and the product. We are patients. We're not clinicians. We are patients who develop products for other patients. So we're very patient-centric. And we've done that over the last 12 years in constant collaboration with our clinician colleagues, mostly consultants, in this case, pediatricians. We're on our 3rd generation of product, and we've just tested it in Norfolk and Waveney, and we have very good reports back from patients, usability scores of 4.5 out of 5, and particularly they seem to like our support. So we're not clinicians, we don't give clinical advice, but we are available 7 days a week from 9 o'clock in the morning to 6 o'clock in the evening to give that support, and that seems to go down really well with patients. This slide I have to say I've culled from a great presentation by Professor Will Carroll, who's an NHS consultant paediatrician. And this really shows the impact, particularly in carbon emissions, of a child or young person being admitted to hospital with an asthma attack for a short stay, so 4 hours or so. And when you compare that with the carbon emissions from even the metered dose inhaler, the MDIs, that everyone gets quite upset about because of the propellant gas, carbon emissions from a preventer are tiny compared with emissions, and very small compared with a can of Coke, a motor car, or even a hamburger. And it's been no surprise that when we looked at the distances patients were traveling to outpatient clinics, we're actually seeing something quite similar, around 4 kilograms of CO2 per outpatient appointment, because we've got a carbon calculator built into our platform. And again, no surprise that carbon actually follows cost. So the cost of prevention is £2.50 a month for an inhaler, and a trip to A&E and a short-term admission by an ambulance is well over £1,200. So the Asthma Plus Me platform, and apologies for the really busy slide, comprises of 6 really key things that were evidenced by a great study by Hilary Pinnock and her team back in 2015. And there are 6 things that patients have to do well. And it's really quite complicated. There's a lot for parents and carers to take on board, and there's a lot to learn. And again, I think that the way that we deliver this information and we support patients to be activated through our app is basically the reason for success. But critical is education, support, primarily from non-clinical sources. So this is peer-to-peer support or a professional health coach to actually increase engagement and motivation, but also to give the parents, carers feedback about how well their child is doing from connected medical devices, and especially inhaler trackers to track adherence. And that turns out to be pretty key. So what we're looking at the moment, and we've been developing this really since 2015 on our 3rd generation, is that the waiting times for the first appointment after a child or young person is referred to a consultant paediatrician in secondary care, either because the GP is concerned about their lack of asthma control or because they've had a hospital admission, is getting worse and worse over this period. It's now standing on average at around 18 to 24 weeks for that first appointment with a consultant paediatrician. And this is actually quite a scary time if you're a parent. Some trusts are much better than that. Some trusts are a lot worse, but the average from England is 18 to 24 weeks. So in our study, what we did was we looked at 31 patients who were who volunteered via 2 hospitals that we worked with, and looking at the adherence levels from their inhaler tracker, we could divide them into 3 groups. The low adhering group, those that only use their inhaler from 0 to 49% of the time, had the lowest asthma control, as you might imagine. The medium group achieved pretty good adherence, actually, between 50 and 79%. I typically average around 85% with my asthma, so not even I'm perfect. And then group 1 actually had higher than 80% adherence and had excellent asthma control. But within group 1, with very high adherence, there were 1 or 2 individuals who still didn't have good asthma control despite near perfect adherence. So what we're working with, what we're working on with the consultant paediatricians is, can we actually refer back to community care groups 1 and 2 that actually had pretty good to excellent asthma control, so they don't need to be stuck in the outpatient system, which tends to get quite sticky. And the ones that are in group 3, they can then be referred on to follow-up clinics because their asthma is either not under control, or they're not able to cope with the care plan, or perhaps they should be considered for biologics. So in essence, 2 out of 3 of those children and young people could be discharged from the outpatient system back to community care and spend more time in school. They might not always appreciate that, of course, but that's really good for their education. And the 1 or 2 who had near perfect adherence but actually still had poor asthma control need to be booked back into the outpatient system for follow-up, because either they need to have their medication reviewed, or again, they might be appropriate for escalation of treatment. And the impact that this has potentially on an ICS is really quite significant, because if we can actually prescribe Asthma Plus Me at the point of discharge from their first asthma attack and hospitalization, work with them for 20 to 24 weeks or whatever it takes to get their first appointment. When they have that first critical appointment with the consultant can see what level of adherence they've achieved, how well their asthma control is, and might not need to see them again. Whereas the typical process would be to book them in for a follow-up 3 to 6 months later. The ones in group 3 obviously need to be seen again with the optimization of their treatment, and potentially these small number who had perfect adherence but still have poor asthma control need to be followed up after review. And we think by doing this, we should be able to shorten the waiting times from about 24 weeks to 12 weeks or less, simply because outpatient appointments are not clogged with people that otherwise could do really well. What was really key was looking at where some of these patients came from. We know from previous data that patients in this region that are in the 20% most impoverished households actually had a 2.2 times increased chance of being admitted for their asthma than the most affluent households. And this really aligns very closely with the Core 20+5 initiative of looking at the people that have poorer asthma control, but also perhaps their circumstances indicate that they are going to struggle. And what we saw from these data from this small study is that there were more children and young people from the third most impoverished homes on the trial than from the rest. And I don't think this was because they were selected or there was a bias in the trial, but actually that reflected the hospital patient community. But what it did show was that if given the training and the tools and the support, over half of those children and young people from the 20% most impoverished group could actually achieve really good or moderate control and spend more time in education to maximize their life chances, which is really important to us. And on top of that, of course, there's the carbon saving. So if we're saving 4 kilos of CO2 for every outpatient appointment and 125 kilos for every admission, that's really significant. So just to finish off, we were asked for our ask. We would really like to work with other NHS trusts that have got very long waiting times for first appointments, which are really critical. We want to work with trusts to see how we can reduce that waiting time and then publish in a peer-reviewed journal. These are my contact details, but more importantly, I've got a few seconds just to introduce the lovely Malcolm here. Malcolm has been using Asthma Plus Me really since its inception. He's got severe asthma and is doing extremely well, not had any asthma attacks since he's been using the platform. And we're particularly proud of Malcolm's achievement because his dad is our software director, so it gives immediate insight into why it works. With that, I'd like to thank you for your time and attention today, and I'll leave it there. Thanks ever so much.
Fantastic. Thank you, Kevin. Really nice to see Malcolm at the end there. Always nice to see a true story of someone seeing benefits. So please do continue in the chat if you'd like to with Kevin, or any question and answers in the Q&A function. But as I mentioned, we're really pushing it with the time scale, so we'll move on to Dafydd from Concentric Health.
Good morning all. Thank you so much for the invite. So I'm just going to share my screen. Hopefully you can see that okay. So I'm going to take the opportunity this morning just to share some work that we've been doing around a concept which is shared carbon considered decision making. So this is essentially 15 minutes as a summary of an SBRI and NHS England funded, HSN supported piece of user research that we did exploring the acceptability of introducing carbon impact into shared decision-making conversations. So this was published, and you can kind of read the full write of the work in the RCS's bulletin that was published end of last year. So just introduce myself. So I'm Dav. I was a clinician by background, so I was a urology reg, then went and did one of the kind of FMLM type clinical leadership fellowships. But since 2015, 2016 or so, I've been more and more within health technology, alongside some roles in shared decision making. So, for example, I was Public Health Wales clinical lead for shared decision making for a couple of years. But since 2019, I've been leading Concentric Health, which was kind of a side project, pet project for a number of us clinicians for a number of years before being funded to take it on as a kind of proper thing. And just to give the context of kind of why we then went and did some of this work. So Concentric is the market leading digital consent platform, launched in 2020, now used across kind of 1/5 of the kind of NHS trusts and health boards in the UK. Basically, simple concept being paper consent forms that are signed by clinicians and patients before any operation procedure, that kind of stuff, digital transformation, that process. So the things we've demonstrated in terms of that shift is certainly it improves shared decision-making quality. It's had quite a big role in terms of elective recovery for places, paperless pathways, remote consent, but also reduction in day of surgery delays and cancellations. So essentially within that context, in particular the shared decision-making impact that Concentric is having, then we were invited to explore what our role could be in supporting a net zero NHS. So just to take a kind of second before we kind of dive into the work that was done, I want you to each think a little bit for yourselves and think, should patients consider carbon impact when making treatment decisions? What do you see as some of the potential benefits and kind of risks or pitfalls of introducing that kind of thing into these discussions? And then also, because there's always a limited amount of things that anyone can focus on at any one point in time, where does that sit in terms of relative importance compared to all the other sustainability initiatives that we could be doing in healthcare? So just in terms of what we did, so what we wanted to do was get a feel for where are we currently in terms of people's mindsets of, okay, there's this shared decision-making concept, two experts in the room, clinician is the expert in the kind of medicine, patient is the expert in themselves. And, you know, that's been a journey over the last 10, 20, 30 years to get to a more patient-centered kind of position, particularly in the UK. And so where are we with that, and considering kind of carbon impact in that context? So we did interviews with 281 patients and clinicians, kind of more patients than clinicians, but kind of a reasonably good split. And these were structured user research interviews where we gave them kind of scenarios and things to think about and saw their responses to different things. So the results at a kind of high level is that there's kind of huge range, totally broad range in terms of people's approach to whether this is a good thing or not. Very unpredictable who would say what. So many in both camps kind of surprised us in terms of how they were thinking about this concept. But there were a few interesting insights, so I'll just kind of pick out a few of these just to kind of tickle your brain cells. So for both patients and clinicians, patient health is the top priority, which is not, you know, a huge amount, not a huge surprise. So however much they care about planet as an individual, neither patients nor clinicians were really prepared to accept worse health outcomes to reduce their carbon impact. So health, top priority, that kind of wins the game. But this was quite interesting and wasn't something we expected to hear particularly. So patients generally, and especially, but definitely not exclusively, especially those who are more environmentally kind of aware-minded, told us that in cases where long-term outcomes would be the same, they would opt for a treatment option that left them less comfortable, because it was kind of one of the scenarios we played through with them. So they would accept being less comfortable in the short term if it had a lower carbon impact. So this kind of quote is one of a number of similar quotes, actually. So if I could suffer through that initial short initial discomfort and think, yeah, it's fine because the long-term goal is the same, but it's having a smaller impact on the world, then I would be like, okay. But unsurprisingly, the acceptance of kind of introducing carbon impact into these conversations generally increased as condition severity and urgency decreased. So when you were talking about, you know, totally urgent cancer cases and that kind of stuff, it was different to the elective non-urgent setting. But actually it was quite difficult to draw a line of where you might kind of say, yep, it's reasonable to discuss versus not, because the individual's own assessment of severity in those different scenarios and cases that were played to them was very variable. So it wasn't that we could draw a line to say, okay, in these sort of cases, totally easy to talk about carbon. In these sort of cases, you know, not accepted by the patients. And then lastly, in terms of kind of an operational challenge that we explored, was that timing and the kind of framing of this is really tricky and needs careful consideration. So there seemed to be a really challenging and narrow sweet spot in terms of timing for these conversations. So patients really didn't want to be discussing the kind of carbon impact of different alternatives straight after having a diagnosis, but equally didn't want to be thinking about it on the day of surgery. And the challenge in terms of kind of shared decision making, treatment decisions, consent processes, in the NHS is that there isn't really an obvious clinician-patient interaction in that gap, in that sweet spot. So these conversations might happen in clinic, kind of shortly after diagnosis, or they might happen, and kind of inappropriately so often, that consent process might happen on the day of surgery. So the conversation was around, it would be nice to talk about it in this kind of sweet spot, but operationally that sweet spot doesn't really exist currently. But there definitely is a desire for some change, although kind of cautiously. So when we ask patients, do you think clinicians should consider carbon impact as part of the recommendations? 40% said they should. So still a majority said no, but 43% said they should consider. And whilst there was some difference in age here, it wasn't kind of totally clear cut. So in the older generation, it was kind of 70-30 to saying no, but in actually kind of the 20 to 40 range, it was flipped. So 60% said yes, 40% said no. But one of the big challenges, particularly from the clinician group, is that there's a huge amount of kind of discomfort with uncertainty. So clinicians would say, lots of quotes like this: "I'm completely unaware of what the carbon impact would be. I wouldn't feel qualified to discuss that." They just don't have the skills and tools to kind of go and incorporate this into their conversations. But maybe that's changing. So the GMC outcomes for graduates recently changed to introduce, newly qualified doctors must be able to apply the principles, methods, and knowledge of sustainable healthcare to medical practice. So it's kind of coming into curriculums and that kind of stuff from there. So that might change. But so we then kind of played through some scenarios of, well, how could we go from current situation, generally not discussed, and clinicians not knowing kind of how to discuss it, not feeling comfortable with that. What's the kind of hierarchy? What's the ladder to get to a point where you can say, yeah, we're introducing carbon impact into conversations as a kind of normal practice? So it felt as if there was this kind of hierarchy of needs. So firstly, that feasible and lower carbon treatment options exist. And then coming back to that kind of health being the top priority, that all those treatment options provide essentially equal outcomes, or kind of no significantly worse health outcomes. And then that the clinician had enough information about the relative carbon impact, and then a way to discuss it. So not just knowing it, but kind of knowing how to structure that, how to bring that into conversation. How does that fit? But then also that thing around patients being receptive, so that thing around severity, timing, all of those kind of stuff. So is that likely to be a receptive part of the conversation given that individual patient in the treatment context? So in conclusion, our feeling from these 280 interviews was that it is sometimes feasible and desirable to introduce carbon impact into shared decision making conversations. And then actually the desire to do so was seen in both patients and clinician cohorts. It wasn't that patients were saying totally yes, clinicians were saying totally no, not appropriate. It was really mixed between the two. But that there are lots of different kind of things that need to be considered on a patient level, and a huge amount of work that needs to go on, research, system changes, educational challenges to be faced before we can really expect carbon impact to be regularly, appropriately, and usefully introduced into shared decision-making conversations. But my feeling is that actually listening to those conversations, that this work should be done, and it's probably not a bad kind of moment in this carbon journey to start thinking about this, because it can play an important role in the journey towards net zero healthcare, particularly given that the expectation, especially if you look at that, generational difference in should clinicians be considering, this is likely to change and become more desired from a patient perspective over time. So thanks so much for the opportunity to share. I think it is genuinely interesting work, and it's quite an interesting write-up. So there's a link there, there's a QR code, and I might just put the link in the chat so you can read it if you so wish to. And more broadly, if anyone's kind of interested in the work that we're doing in Concentric around digital consent and shared decision making, my contact details are there. So thank you so much for your time.
Perfect. Thank you, David. That was really, really interesting. Really good to see those patient and clinician perspectives. So really enjoyed that. So thank you, and we will move swiftly on. Just a reminder, please do use the Q&A for any questions for anyone speaking or in general, and the chat if you'd like to continue the conversation with anyone during this event. So moving on, we have Adrian from Itecho Health. So I will hand over to you, Adrian. Thank you. Are you there, Adrian? Is it frozen for everyone or just me?
Frozen for me too. Looked like he was good to go.
Coming through now.
Ah, there you go. Here you
Yeah.
are again. Welcome.
Yeah, carry on, Adrian. Just froze for a second there.
Can you see my screen now?
Yes, thank you.
Okay. Thank you for the invitation to speak. So I'm going to talk about our platform, which is called Salus and has a carbon tracker, which has been developed for the virtual management of patients living with long-term conditions. So Itecho Health is a digital health company led by clinicians and technology experts. We've developed this AI-driven platform called the Salus for virtual management of long-term conditions and also reducing carbon emissions. The Salus platform and myself are part of the NHS Innovation Accelerator, or NIA, and I'm an NIA fellow in the 2023 cohort. So healthcare systems are under strain, I think particularly the NHS, and demand for long-term condition management continues to grow and is outpacing supply, which is resulting in longer waiting times and reduced quality of care. And what's driving this is an aging population, increased life expectancy, and also new treatments coming on board that are very rarely magic bullets, and most of which require ongoing monitoring. So we're getting this gap between demand and supply. And on the supply side, we've also got staff recruitment problems, and the budgets are not keeping up with the increasing demand. So why focus on long-term conditions? So there's about 120 million people in the EU/UK and 130 million in the US that are living with at least one long-term condition, including cancer. And increasing proportions of healthcare budgets are required for these conditions, and that's over 70% in the UK. And we all know that COVID-19's had an increased pressure on capacity, and we've now got the worst ever waiting time. So we need more productive and economic models for monitoring patients. In terms of how this is traditionally done in the outpatient setting, from the NHS England net zero team, I believe the calculation is that over 5% of the current NHS emissions are due to patient travel to hospital. And the majority of these travelling is to attend outpatient appointments. And outpatient appointments doubled over the last 10 years prior to COVID. And the majority of these appointments, which is nearly 100 million appointments a year in England, are for patients with long-term conditions. So that's 51.6 million appointments per year, according to the NHS digital figures. So what we're able to do is reduce the growing gap between demand for and supply of care for patients living with long-term conditions and reduce CO2. And we've got a staged strategic approach which is applicable across healthcare systems globally. The first of those is asynchronous virtual reviews, and I'll come on to that in a bit more detail. The second is to actually automate the reviews using existing algorithms. And then the third stage is to automate using supervised machine learning. So we're reducing the need for face-to-face appointments incrementally with each of those steps, allowing consultants and other medical staff to spend their time focusing on patients with complex needs and dramatically reduce the number of patients that need to attend outpatients. So we've built this platform through extensive co-design with patients and clinicians. We've developed a patient user mobile application that collects comprehensive data on symptoms, side effects, quality of life measures, and connects with wearable devices and other sensors around to provide vital signs monitoring. And complementing this, we've developed a clinician portal which integrates with hospital IT systems so that then clinicians can do asynchronous virtual reviews of patients living with long-term conditions. And we've also developed within the platform an initial CO2 tracker so that we can actually calculate the reduction in CO2 from the shift to virtual reviews from face-to-face appointments. So the platform dramatically reduces the need for face-to-face appointments that directly then impacts on CO2 from reduced transportation. And from the Health and Social Care, so the Department of Health and Social Care's figures, the average outpatient attendance creates around 22 kilograms of CO2. So one of the conditions, for example, prostate cancer, where we're working, we're reducing the number of face-to-face appointments from 12 to 6 annually. So that achieves a reduction of 132 kilograms of CO2 per patient. There's obviously additional benefits from actually reducing the impact of the outpatient service itself in terms of the energy and running costs and water requirements. We've been successful in getting funding from the National Institute for Health and Care Research through their Invention for Innovation Challenge Award, a £2.2 million grant, and that's a collaboration which we're leading with 3 NHS Foundation trusts, 3 universities, and 5 patient-focused charities. And that this is looking at digital transformation of the management of long-term conditions in haematology. So we've basically looked at all the potential diseases in haematology which we can move to digital. And so there's 8 conditions that we've identified, and there's around 5,000 patients in this study at the moment. And if that was to be extrapolated across the country, there's more than 1 million people living with these conditions, so it's a significant cohort of patients. And so what we're doing with that is looking at the improvements in patient experience, looking at the health economics of moving to digital, but we're also looking at the carbon impact, and that's been in collaboration with the University of Leeds. So we've currently got the carbon tracker, which simply calculates the CO2 reduction in terms of the number of appointments, face-to-face appointments that we've avoided using that average figure. But we're trying to develop a more sophisticated carbon tracker and using patient surveys of their usual travel patterns and travel choices, and using GPS and their patients' postcodes, hospital postcodes, and so on. We can then get very precise data on the impact and reduction in CO2 using the platform. Also, as part of this project, we're getting patient insights in terms of whether they want to move to more sustainable healthcare pathways. And we've got 3 service user advisory groups, one for patients who have low levels of digital literacy, one for those that have high levels of digital literacy, and then one which is particularly looking in sickle cell disease. And one of the things that we're testing with those groups or exploring with those groups is the looking at greener care pathways, and one of the things we're doing is using what's called discrete choice experiments to look at the trade-offs between CO2 reduction and some of the benefits of face-to-face appointments. So that data will be coming out over the next 6 months. I think that's probably all I wanted to say. Yeah, thank you.
Brilliant. Thank you, Adrian. That was really interesting. Again, I will just say, please do pick up in the chat if you'd like to speak to Adrian further, or if you've got any questions, please pop them in the Q&A. So we are slightly ahead of schedule, which I'm not going to complain about. But if we do have Crystelle from Definition Health on the call, I will hand over to you. Thanks, Crystelle.
Hi there, thank you. Let me just share my screen. Can you see my slide deck?
Yes, thank you.
Excellent. So thank you. Yes, my name is Crystelle Waters. I'm the Chief Digital Nurse at Definition Health. Definition Health was founded in 2018 by 2 NHS consultants, and we deliver a suite of total surgical solutions that tackle challenges that face patients and staff across the perioperative pathway. These challenges, I'm sure we all know about them. For patients, there's the long waiting lists. There's almost in excess of 7 million patients waiting for surgery at the moment. Often patients describe that they don't have little visibility about treatment or options that are available to them. Support materials that are given to them, if they're given at all, are often generic and impersonal, and patients report feeling isolated, and this can lead to reattendance to GP surgeries and A&E departments. Amidst all of that, we have a staffing crisis. There's currently 40,000 UK nurse vacancies being advertised. And we obviously have the carbon footprint target by 2040, and the cost of theatre cancellations, £200 to £400 million, and that 30-day readmission costs the NHS £2.6 billion per annum. So it's quite a challenging environment that everyone's trying to work in. Our digital solution is proven to solve this. We have a robust clinical working team at Definition Health. We go into hospitals, trusts, and we map out their current processes and look at how we can digitize them. And I'll go into a bit more detail about how we do that. But the sort of bottom lines are we're reducing those multiple trips to hospitals. They're avoided. For a patient experience, family and friends are able to support patient as they embark upon their preoperative journey. There's information that's automatically mapped to patients' portals, and that information encompasses specific procedure information, anaesthetic conditioning and consent conditioning, and the patient has to engage with that information. They have to tick that they've watched the videos and they've understood the content, and that is really important to feed into that shared decision making piece of work. That's really important at the moment. Patient, all the information is in the one place, and of course there's those cost savings there. Hospitals experience more structured clinics, more efficient appointment allocation, there's earlier triage of patients, better prehabilitation and education of patients. That risk stratification is earlier and feeds into those efficiencies, and you're able to create a pool of surgery-ready patients to fill in any of those last-minute theatre cancellations, which hopefully will be less. There's a reduction of reattendance and readmission because patients have that better digital support, and we are an end-to-end solution, so we also follow patients post their surgery once they've been discharged via our recovery platform. One of the wonderful byproducts that comes with digitising pathways is the carbon reduction piece, and that's done by reducing the travelling for patients and staff, getting rid of those paper pathways and the paper information, by replacing that with digital information. And there is some benefit when patients are better optimised pre-surgery. It does reduce the amount of anaesthetic gas that's used. However, it is that reduction of travel and paper usage which has the most dramatic impact. So what do? We deliver a Definition Health patient app to patients. So patients are securely connected to the healthcare professionals, to their trust, to their hospital. They log in and they are greeted with a user-friendly dashboard that outlines what patient tasks they need to complete in order to come in for their elective surgery. They complete a pre-surgery questionnaire, and there are also post-surgery questionnaires. They are delivered that video education I referred to earlier about procedure, consent, and anaesthetic conditioning. There's this very unique bi-directional file sharing between the hospital and the patients. The patients can share information, cardiology reports, echo reports with the hospital, and equally hospitals can share information with patients. This is really key and really important in that prehabilitation of patients, making sure the patients know what lifestyle changes they may need to make to optimize their health before coming in. Virtual clinic and appointment management. There's a virtual recovery ward and those outcome scores that are associated with that. The hospital experience, the hospital users are delivered with a smart dashboard, which really improves their workflow and process because they can monitor how patients are progressing through that journey. They can, using an array of smart filters on the dashboard, so you can generate work lists of patients, those who are ready for admission to slot into those theatre slots, those who are on hold, and you can get into quite specific granularity to understand why a patient is on hold, if they've been deferred, if there's some clinical reason why they can't progress. Remote working is facilitated. Patients can be interacted with virtually in real time, and it is that communication piece of work. The virtual ward recovery functionality, the patient is delivered with a set of questions post their discharge. They are able to track their pain management, their wound management, their mood, their sleep, and hospital teams are able to keep a track of that on a recovery dashboard also. Any significant concerns are flagged immediately to the hospital so they can identify if a patient does need to come in again for a check, if they need to go to their GP, or indeed if they may need to go to A&E. So Definition Health has always likes to deliver robust clinical evidence through real-world studies to prove our benefit. We've done some earlier studies with some of our clients, Swelliok, Wrightington, the Montefiore, and it does show quite dramatic reduction, particularly in those face-to-face appointments and the streamlining of the perioperative processes. We are, however, quite proud to be able to say that to add further weight to our claims, we were validated in an independent real-world validation study that we embarked upon as a result of an SBRI grant with the following partners as listed on the screen. And the utilisation of our solution was studied in its health economic analysis and highlighted some incredible financial and staff resourcing and sustainability benefits. So we were able to show the changes in the preoperative pathway outcomes, and it's that reduction in the 60-minute face-to-face pre-assessment appointments, that increase in shorter appointments done over the telephone, and that reduction of the patients who weren't attending appointments at all. The baseline was 6.3%. And that reduced right down to 0.6%, which is really important. And that is because patients do engage with the platform. Definition Health recognises there is there's 21%, I think it is, of people in the UK who experience digital poverty, and we have an assisted digital pathway for that cohort of patients. So that those patients who may not be as digitally literate are still supported and able to go through a separate pathway. We always get feedback from our patients, and you can see our NPS is 44, and we do get some incredible feedback. But going back to that real world independent study that we did with Royal Surrey, so we looked at over 12,000 patients, and as I said, it was the largest benefit stream was that reduction in the hour-long pre-assessment appointments. But the study did show that cost savings over 5 years would amount to about £422,000, and that's a return on investment of 39%. And if that was to be extrapolated over the entire Surrey Heartlands ICS, that would increase further to £1.94 million over 5 years. So it was quite dramatic. those cost savings can be further broken down, and you can see there's that CO2 piece there, that reduction of travel, reduction of paper, which is quite significant. And, you know, one of the keys to our success is our ability to transform these sometimes quite complex hospital pathways and processes, but also behaviours. People like the idea of change until they have to engage with it generally, but we're quite passionate that we have clinical teams that work with clinical teams on the ground. And as a result of that, we had a wonderful outcome for Royal Surrey, who successfully were awarded the HSJ Award for Best Elective Care Recovery Initiative. So we know we can streamline these processes, and we have identified that there are some sustainability benefits, but we deep dived into this bit further. And with the help of another SBRI grant, we engaged on a defined 6-month study with a trust down in Brighton, looking at a patient group of about 1,000 patients. And it was to map out the pre-assessment pathway and show the progress of carbon reduction. So there were about 1,400 episodes there, but I think it was just over 1,000 patients in total. Some of them were serial episodes that we looked at, and it showed we took our learnings from Royal Surrey, in fact, which I think they in total had a reduction in their face-to-face appointments of 35%. This trust in Brighton showed reduction of 80% reduction in their face-to-face appointments, and there's that carbon reduction identified with that appointment and associated travel. The digital file sharing had quite a dramatic engagement with it. 2,000 files were shared by the hospital to patients, and patients were also sharing information with their hospital. That post-discharge virtual ward also allowed us to see some reduction in carbon. And, you know, patient experience wise, there was also improvements in wound and pain management. So for the project, and that was just over 1,000 patients, there was 9.44 tonnes of CO2 savings. Extrapolate that across the trust in entirety, and it would be 445 tonnes of CO2. And that is a greater carbon saving, in fact, in changing that pathway than would be observed in the operating theatres. Just quickly, I know I'm running out of time slightly, but I just wanted to drop a couple of slides that a consultant in East shared with me a few months ago about the carbon footprint within the NHS. It is monumental and dramatic. And finally, just a few statistics here, just for you to absorb really about the healthcare climate footprint. And quite interesting, if health sector were a country, it would be the 5th largest emitter on the planet. So it is the global climate crisis is the greatest threat, but I'm really excited that we're all reframing that to be the greatest public health opportunity, really. Thank you for your time.
Brilliant. Thank you, Crystelle. That was really interesting, and a massive amount of impact and outcomes that you've been able to show there. So yeah, thank you for that.
Thank you.
Again, we are slightly ahead of time, which I'm impressed with. Just goes to show everyone's excellent presentation skills so far.
Great.
Fantastic. Thank you.
Thank you, Darren.
Brilliant. Thank you. That's what I like to see. Lots of collaboration and opportunities opening up. What we're here for. Is that Hemmel who's just joined us? Yes. Hello. Thank you. We're running slightly ahead of time, which I'm pleasantly surprised by. So we were just doing a little bit of chatting while we waited. So yes, we have Hemmel from Digistain. So if you are ready, Hemmel, I will hand over to you. And yeah, thank you for joining us. Oh, you're on mute.
Mute me myself.
Thank you.
Hi. Yeah, thanks for that. Oh, thanks for waiting. How long were you waiting for? I hope not too long.
Only a few minutes. It's yeah, we're
okay,
ahead of time, which is
really
surprising
unusual.
but good. Yes.
No worries. Okay, cool. Let me. Am I ready to share my screen?
Yep, go ahead.
Okay, bear with me. How's that? Can you see my screen?
Yes, thank you.
Brilliant. Okay. So, hi, I'm Hemmel, founder of Digistain. which is an Imperial College spin-out technology, which enables rapid decision-making for oncologists using an AI-based approach for their breast cancer patients, and making better treatment decisions with their breast cancer patients. So breast cancer today is a national priority. About 30 patients a day die in the UK from breast cancer patients. 5 million hours are wasted, anxiously in anxiety for test results annually. And there's a huge unmet need today for better decision making. The fact is, about 10 years, just over 10 years ago, it was discovered that about 25% of breast cancer patient deaths were attributed to the overtreatment of chemotherapy. And this has given birth to a new kind of diagnostic, which I'll be sharing with you in a moment. The problem with this new kind of diagnostic, however, is that there are huge healthcare inequalities, both resulting from economic status, as socioeconomic status, as well as ethnicity. So today, this test that is used to identify the low-risk patients who can avoid chemotherapy for the economically deprived people and also the Black and Asian patients, 46% of them, firstly, are globally less likely to receive this life-saving diagnostic. And also the patients that do take them, because they rely on genomic analysis, and these tests are genomic tests which have been validated on Caucasian patients. The Black patients who are scored as low-risk patients who would then not receive chemotherapy are twice as likely to die as their Caucasian counterparts. So the fact is that this new standard of care that's been introduced to the NHS is not really compliant with its long-term plan, nor compliant, nor aligned with the Core 20+5 strategy. And the current standard of care, therefore, won't meet that scalable impact with the cost and the time limitations. Because here's the kicker. Most of these patients, all of these patients for this test, require their patient biopsy, that's removed during surgery, to be shipped all the way to California in the USA. And most breast care physicians are shocked to learn this, the simple fact. And of course, we're here today to discuss the environmental impact. You can imagine the environmental impact that creates, the negative environmental impact that creates. So because of the fact that these patient biopsies are being shipped all the way to California, it means that treatment decisions are delayed by up to 4 weeks in the UK, because this testing is carried out in centralized laboratories. Needless to say, a 30-day delay has showed us over COVID is responsible for a 13% mortality risk. And of course, because of these tests are so expensive, at $4,000 each, it means that these treatment decisions are impacted massively, meaning because of the fact that doctors don't like to use these tests, unless they absolutely have to. Globally, of course, this means that most patients will never be able to afford $4,000 per test. So we set out from Imperial College, based in Charing Cross Hospital in the UK, to respond to this problem. And we designed a tool which delivers a result in 24 hours without having to ship samples all the way to the US. It was designed with over 1,500 breast oncologists. So we sought input from over 1,500 breast oncologists to make sure that we were creating a solution to a problem that they defined for us. The validation, it's been clinically validated, and this clinical validation study was reviewed by Cancer Research UK. And because it relies on almost exactly the same laboratory procedure that is carried out in every hospital in the world, let alone the UK, it means that it's seamlessly integrable to existing clinical workflow. There is no need to send samples off to the US. There is no new technology. There is no new laboratory procedure required to be performed in the UK. People can rely on existing infrastructure. So today we've achieved the same regulatory status as the incumbent used by the UK. We've assembled a stellar advisory board, a clinical advisory board, comprising the head of pathology at Cancer Research UK, the proponents of the incumbents, in fact, have left the working for the incumbent and are now working with Digistain to spread the innovation globally. And indeed, we've got hospitals all over the world using Digistain today. And we're here today to discuss the the environmental impact. So we commissioned a study, an independent study commissioned by Innovate UK, where it was showed that when this test is used in lieu of the incumbent, there is, first of all, no extra risk to the patient, because our sensitivity and specificity for an 800 patient study was shown to be identical to that used by UK physicians today. And when using Digistain in lieu of the incumbent, we see up to an 850,000 tons of CO2 savings annually. So it's a massive, significant change in the environment, and positive change in the environmental impact. So the system impact it results in something which is far more aligned with the net zero commitments of the NHS, but also the healthcare inequalities. And here is a testimonial from the head of pathology at Northampton General Hospital here in the UK. They've been using the US-based test for a number of years, and they're pleasantly surprised with Digistain. It's cutting down the time for results massively when compared to sending the samples off all the way to the USA. So it's quicker and it's more cost effective. Clinical validation study. The results have been shared across globally at the American Society of Clinical Oncology. And finally, just a quick shout out to all of the media coverage we've had recently because of the potential impact that Digistain can have on the UK healthcare system. We've been featured on Sky News, BBC, Bloomberg, Daily Mail, etc. Finally, a huge thanks to our supporters, who include Harvard University, who funded Digistain, and also Y Combinator, and a number of UK institutions, both private and public and charitable. And we've won a number of startup awards as well. Thanks for your time.
Brilliant, thank you, Hemmel. Really interested to see the kind of reach that you've got there. So again, we're still slightly ahead of time, but we'll move on, and then we can do some questions at the end or further kind of reflections with any time we have left. So if we have Federica from Patients Know Best, I'm happy to hand over to you. Thank you.
Hello, I'm here. Thank you, Nicola.
Thank you.
Let me share my screen. Sorry, I'm not too familiar with Teams, so it might take me a while.
It's okay. We've got time. Don't worry.
So I think this way I'm sharing my whole screen.
You are.
This is not what I wanted. So share window. It only gives me the option to open Microsoft Teams, which doesn't make sense. Okay, I guess I'll share my whole screen. I hope you can see my screen.
Yeah, perfect. Thank you.
Okay, apologies, I'm not too
okay.
tech savvy. So thank you very much for inviting us here. I'm Federica Andreoni from Patients Know Best, which we call PKB, the acronym. I'm a Success Project Manager and Sustainability Officer. So my plan for today is to firstly provide you with the background of PKB. So in terms of who we are, of course, and what we do. I'll then cover how we've supported NHS organizations in reducing their own carbon footprint associated with the delivery of care. And I'd like to finish on what we've done as an organization to ensure that we are a net zero provider to the NHS. So ensuring that NHS organizations don't have to account for our footprint within their Scope 3 emissions. So I'd like to start with a really short background. So PKB was founded in 2008 by our founder, Dr. Mohammed Al-Obeidli. Mohammed is both a doctor, a clinician, and also a patient because he was born with a long-term rare condition. 15 years later, now we're the largest patient health record or personal health record platform in Europe. We have more than 3.2 million patients registered, increasing by around 100,000 more registered patients per month. And we have patients accessing over 16 million test results every month on our platform. So this hopefully gives you an idea of our numbers. So our aim is to put patients at the center of their own care. As you can see here in this slide, we're integrating around the patient. So what we do is two main things. First, we provide patients with access to their own health data. Second, we provide them with the tools they need to self-manage their conditions and identify deterioration early. This way, we're changing the way that care is delivered, focusing on prevention rather than reactive treatment. So data in our PKB platform flows from each healthcare provider to the patient, as you can see here. The patient can see this data, contribute to the data, so the patient can add its own data. And the patient can also share this data with whoever else needs access to it, including carers, family members, friends, and other care collaborators. So by supporting citizens in accessing their own information, we enable them to be collaborators in the care that they receive and adopt healthy lifestyles that help keep them well. And for those with chronic conditions, we in fact give them the ability to self-manage. So in effect, we're enabling people to self-care and take control of their own conditions. So as mentioned, we not only provide the data, but we also provide a range of digital tools that facilitate patients interacting with their health and care professionals remotely. These tools include asynchronous messaging, so patients and professionals can message each other. Also, carers can be included in a thread. And within these messages, both patients and professionals can add attachments up to 10 gigabytes. We also have a questionnaires feature, so professionals can send patients questionnaires to fill in. And we also allow for remote monitoring via integrated apps, devices, and wearables, so people can connect their Fitbits, for example. And we also have a symptom tracking feature. So these digital solutions are pivotal to the case studies which are covered in the next few slides, which are focused on how NHS organizations have used PKB to reduce their own footprint. But a key capability that I wanted to stress within Patients Know Best is the collaborative care planning. This enables individuals to co-produce care plans with their health and care professionals. So this improves patient outcomes and supports the personalization of care. As you can see, we have these little tags here at the bottom of the slide because the platform is translated into 22 different languages, and additional ones are easy to incorporate into the platform. And this slide is to show you that PKB has the broadest and deepest integration with the NHS app. So all of these features that you see, such as messages, care plans, test results, symptoms, etc., are all available directly within the NHS app. This enables patients to access their health and care record and the digital tools that they need to access to manage their health and well-being. And also, patients can register to PKB using their NHS login. But now in the next few slides, I'd like to talk about how we've supported NHS organizations in reducing their own carbon footprint by starting with talking about the delivery of digital letters. So at PKB, we have integrations with hybrid mail providers such as Synotex and Xerox, whereby correspondence is sent digitally with a read receipt check taking place after an agreed amount of time. So if the correspondence has been read by the patient, a physical letter will not be sent. This way we avoid the financial and environmental cost of sending a physical letter in the post. And to date, we have supported over 1.9 million letters that have been sent digitally rather than physically. So we have avoided, as you can see here, 261 tons of CO2 emissions. To give you an idea of how much this is the equivalent carbon cost of 113 heart bypass operations. Sorry. So this slide is about our work with Hull University Teaching Hospitals NHS Foundation Trust. So alongside the carbon footprint reduction associated with the delivery of digital letters that they had, we have worked with the trust as part of their pre-assessment workflow to help them implementing a digital pre-assessment pathway. So this consisted of issuing questionnaires to patients via PKB to determine what level and type of interaction a patient needed ahead of surgery. So the answers are then extracted and inputted to a local custom-built dashboard that is used by the admin and nursing team to triage patients digitally. So prior to the implementation of our PKB platform, the trust would arrange a face-to-face appointment with every single patient which was part of the pre-assessment pathway. But through PKB, the trusts are able to analyze these questionnaires' responses and decide. So they can decide who really needs to be seen, who can be phoned instead of seen, and who doesn't need an appointment at all. So these have saved the trust almost 300 face-to-face appointments. And also, the trust also avoided sending almost 200,000 physical letters across their entire patient population. So as a result of these two things, so avoiding appointments and avoiding sending letters, the trust avoided 25.1 tons of CO2 emissions saved in 8 months. And this is the equivalent carbon cost to 25 hip replacements or knee surgeries, because they emit 1 ton of CO2 emissions per operation. Another case study that I think is really interesting and that I'd like to talk about now is about our work with Luton and Dunstable. So they are using PKB for remote consultations and for the to implement patient-initiated follow-up pathways. And this is also reducing patient travel again. So in particular, they're using PKB to have virtual outpatient clinics and to provide patients with a self-management care plan with symptom tracking. So the care plan is one of the tools I was talking about before when talking about the tools that we provide. So in a year, they have avoided 1,100 outpatient appointments. And considering 6.94 kilograms of CO2 emissions saved per avoided appointments, this is a total of 7.6 tons of CO2 emissions saved. And not only, they also have avoided 240 surgical cases thanks to the use of PKB, which is really good. Okay, so after I talked about how we supported NHS organizations being net zero, I wanted to talk about our own carbon footprint. So as well as supporting NHS organizations in reducing their own footprint, we also wanted to be proactive and accountable for our becoming a net zero provider to the NHS. So this for us is really important, and this is why we decided to remove our entire footprint for 2021 and 2022. So what we've done is partnering with Supercritical, which is the company helping us analyzing our footprint and deciding a reduction strategy together. So we're really proud that we have one of the smallest footprint per employee that's super critical I've ever seen, which is 2.7 tons of CO2 per employee, which is, again, lower than average. And this is also thanks to the fact that we're a remote-first company, and we've always strived to minimize travel as much as possible. So just to clarify, our footprint, so what we calculated includes everything. So our hosting through Google Cloud Platform, employee remote working, business travel, product use, so the use of PKB by patients, professionals, and carers. So we want to take full responsibility of the use of our platform, ensuring that NHS organizations don't have to account for these within their own environmental footprint. And despite our footprint being really low, below average, we identified areas where we could reduce this even further. However, even though reduction is always our preferred option, this isn't always possible. And to tackle the remainder of our carbon footprint, we have purchased permanent carbon removal and sequestration. So the lack of clarity around the avoidance of sets, longevity, and validity, so whereby payments are made to stop others emitting carbon, encourages us to instead focus on permanent carbon removal. So rather than purchasing avoidance of sets, whereby you pay someone not to emit, but your emissions remain in the atmosphere, we decided to purchase carbon removal offsets that directly remove our carbon emissions from the air, so that they no longer contribute to global warming. This permanent carbon removal, in our case, has taken the form, so what we've purchased is biochar and enhanced weathering. So biochar is where charcoal is produced from waste biomass and stored in the soil, and this is a durable form of carbon removal that will outlive our carbon emissions. So not only does the spreading of these on fields provide permanent carbon storage, it has the added advantage of enhancing soil fertility, so this helps with food and land challenges. And enhanced weathering accelerates the natural process of weathering to permanently remove carbon dioxide from the atmosphere. So I wanted to conclude on these notes because as part of our environmental efforts, we're also a certified B Corporation. I'm sure you know, but certified B Corporations are businesses that meet the highest standards of verified social and environmental performance, public transparency, and legal accountability to balance profit and purpose. This brings me to the end of my presentation. I hope it was interesting, and here are our Twitter, email address, so shall you have any questions, feel free to contact us, and we also have a website. I hope you enjoyed the presentation, and thank you very much for listening.
Fantastic. Thank you, Federica. That was really interesting. Really good to hear about what PKB have been doing around their own carbon, about your own carbon footprint as well. Yeah, really interesting perspective.